Jen Kuo from Columbia.
Yes, thank you to the AAES for asking us to moderate this session together. There's nobody else I'd rather be up here with.
Feelings mutual.
We'd like to welcome you to the scientific session. Again, a few reminders to our presenters to keep to their allotted time, and also to any audience members who have a question during the discussion to come up to the microphones and announce your name and institution. So we'll be getting started now with our first presentation from Drs. Lytle, Zhang, Makris, Grogan, and Selleberg from Baylor College of Medicine in Houston, Texas.
All right, hello everyone. My name is William Lytle. I am a surgery resident at Baylor College of Medicine. On behalf of myself and my colleagues today, I'd like to thank you for allowing us to present on objectively measured cognitive dysfunction in patients with primary hyperparathyroidism that improves after parathyroidectomy. These are our disclosures. So there's a known relationship between primary hyperparathyroidism and decreased quality of life that has been shown using patient-reported outcome measures, including PASICA's parathyroid assessment of symptoms, SF36, and PROMIS. These tools provide value in measuring subjective quality of life, but there remains a paucity of information on objectively measured cognitive dysfunction in primary hyperparathyroidism patients. Due to the lack of objective neurocognitive data, current guidelines differ in their recommendations regarding parathyroidectomy for neurocognitive and neuropsychiatric symptoms. Recommendations from the 5th International Workshop on the Evaluation and Management of Primary Hyperparathyroidism say that parathyroidectomy cannot currently be recommended to improve neurocognitive function. And then with the American Association of Endocrine Surgeons, we have one that says that it does recommend parathyroidectomy for patients with neurocognitive and neuropsychiatric symptoms. And this is based on some data, accumulated from subjective tests such as PASICA's parathyroid assessment. Despite these varying guidelines, a universal standard cognitive test has not been, for patients with primary hyperparathyroidism, has not been established. Our overall objective in the study was to assess the association between primary hyperparathyroidism, parathyroidectomy, and changes in neurocognition with brain check in order to determine if primary hyperparathyroidism is associated with objectively measurable neurocognitive improvements and whether parathyroidectomy can improve these impairments. Recently, brain check, which is a tool that can objectively measure neurocognitive function, has become available for use in the outpatient setting. BrainCheck is a clinically validated instrument that allows rapid, objective evaluation of memory, attention, and executive function. This test assigns a score which can be compared to validated age and sex-matched population-level controls. It's a computerized neurocognitive test that is actually available on iPhone, iPad, and desktop. It's previously been validated for its diagnostic accuracy and the assessment of neurocognition, and the reliability of the test has been tested with normal controls over multiple periods of time. It was originally used for patients with dementia, but has since been utilized in many other disease processes as an assessment for cognitive impairment. This is an example of the Stroop test, which is an example of how BrainCheck evaluates executive function. And what is executive function exactly? It refers to the collection of cognitive skills that integrate planning, inhibition, and task switching. It's the mental processes that allow humans to plan, focus, and juggle multiple tasks. The Stroop test evaluates executive function by measuring how long it takes a patient to overcome cognitive interference. The digit substitution test is another test that assesses executive function. It requires the test taker to correspond symbols to numerals based on the key or legend on the page. Our study was a single institution study from the years of 2019 to 2021 and encompassed 59 patients with primary hyperparathyroidism. We evaluated using BrainCheck 2 weeks before and 2 weeks after parathyroidectomy. And our association between BrainCheck scores and parathyroidectomy were evaluated using a Wilcoxon signed ranks test. This table shows the preoperative patient characteristics and medical history of the cohort. A total of 59 primary hyperparathyroidism patients or participants with a mean age of 58.2, 72.9% were female, and 49.2% were white. underwent parathyroidectomy, and participated in the brain check assessment. As you can see at the bottom of the table with the medical characteristics, 64.4% had hypertension, and importantly, 74.1% subjectively reported neurocognitive deficits. The median PTH level was 193, and the median post-op PTH was 24. This is a sample brain check assessment that you get at the end of taking your test. For each domain, brain check provides a standardized numerical score between 0 and 200 that is adjusted for age and sex based on normative data sets that have been previously validated. If a score is greater than 1 standard deviation below the normative range, is considered below average. If it's within 1 standard deviation, is considered average. And if it's above 1 standard deviation, is considered above average. In addition to the score, you get a composite total score that provides, as you can see in this one, it says 105. So you do get a numerical continuous variable as well as categorical above average, average, or below average variables. We then use these to analyze each individual domain as well as the overall composite scores. This bar graph shows the preoperative brain check scores broken down by category. Preoperatively, a total of 26 patients scored below average, suggesting neurocognitive impairment relative to the general population. 19 scored average, and 14 scored above average, and as you can see, it is left shifted. Postoperatively, after undergoing parathyroidectomy, there was a noticeable change towards a normal distribution of scores. 13 scored below average, 29 scored average, and 17 scored above average. This Sankey diagram shows the paired comparison before and after parathyroidectomy in regard to brain check category they achieved during neurocognitive testing. There were a total of 19 patients that scored higher postoperatively, 2 patients scored in the same category, and a total of 64.4% or 38 patients scored higher postoperatively. Of the 26 that had preoperative below average scores, as you can see in the bottom left of this chart, 14 of them increased from either below average to either average or above average. 10 specifically from below average to average, and then 4 from below average to above average. And then 3 actually went from average to above average. To assess if a particular domain was responsible for the neurocognitive improvements after parathyroidectomy, we assessed the preoperative and postoperative scores for each individual domain, which you can see in this table. In the entire cohort, executive function improved postoperatively, while attention, immediate recall, and delayed recall showed no statistically significant improvement. On demographic subanalysis, whites and females were the 2 cohorts that improved, while males and non-white races did not show any postoperative improvement. Executive function 1 and 2, which are the digit symbol substitution and the Stroop test, were associated with improved postoperative brain check scores following parathyroidectomy. Overall limitations, this was a small study population. We did have some attrition due to the COVID pandemic during these years. We didn't really have a control group. And then also neurocognition is very complex, and then, there may be unmeasured confounders that are in the study. So overall, in our study, 44% of primary hyperparathyroid patients showed a neurocognitive deficit relative to the general population. This provides objective data that corroborates previously shown subjective declines in neurocognition and quality of life. We also found that primary hyperparathyroid patients with neurocognitive deficits may benefit from parathyroidectomy as soon as 2 weeks after surgery, which has also been shown previously in the literature. In total, 64% of patients improved their neurocognitive function, which is surprisingly close to the 74% of patients that self-assessed as having neurocognitive decline preoperatively. Previous studies have shown that neurocognitive function may improve after successful parathyroidectomy in primary hyperparathyroidism patients. Our findings corroborate these previous findings with a test that is easy to administer in the outpatient setting. Finally, we found that the main neurocognitive domain that is impaired is executive function. Executive function is associated with the ability to plan ahead, make decisions, have self-control, make moral decision-making, and make more complex coordination of tasks. Given this, it seems reasonable to associate a decline of executive function with the non-quantifiable concept of brain fog that primary hyperparathyroidism patients often describe. In addition, an executive function would also seem to lead to a decline in quality of life. Thus, it appears that our data may show that the underlying neurocognitive change that leads to the previous findings of decreased quality of life in primary hyperparathyroid patients and may explain the concept of brain fog in that these patients often report. Thank you.
Dr. Sturgeon?
Thank you, Dr. Kuo and Dr. Kuo. Brian, thanks for bringing this presentation. It's really fascinating. I have a couple quick questions. What you're doing is taking a numerical score and you're converting it to a categorical score, below average, average, above average. And what I think would be very interesting is to know at a granular level, as these numerical scores change, what is the magnitude that is required for there to be a clinically significant change in neurocognitive function? I think that would be fascinating.
Yeah, that's a good point.
Also, are people reporting to you that they subjectively feel that there's a clinically significant change in their executive function?
Yeah. No, that's a good point. And we're actually trying to broaden our study in the future. Our sample population was kind of low in this one, so we're hoping to, broaden our study in the future, gain more patient population, hopefully identify those specific key findings.
I would also encourage you to do it longitudinally, so more than just 2 weeks. I'd like to see how durable the effect is.
Yes, sir. Thank you.
Thank you very much.
Dr. Mather?
Good morning, Arthi Mather, Baltimore, Maryland. Thank you very much for such a nicely presented study. I have 2 questions for you. So when you looked at the different cognitive domains, was there a difference that you noticed by age? And then second, I noticed that some patients got worse after surgery. I was wondering what you thought about that or why.
Yeah, so the first part, substratifying it by age, we did do that. However, when we did our subgroup analysis afterwards, unfortunately, I think our power wasn't high enough, so it wasn't statistically significant. So unfortunately, I don't have a good answer for that. Second, what was the second question? I'm sorry.
Some of your scores got worse.
Oh, yes. It seemed like there were 5 total, especially that went from one category to a lower category. Whether this was due to, we don't really have their frailty scores or their performance scores preoperatively, so whether or not these were like elderly patients that may have had some, anesthesia effects later on, or just, they just might have performed well. And we also don't know, they didn't really have any incentive to like really do as hard, work as hard as they could to like, get the best score possible. So those could all probably have, affected those aberrant scores.
Thank you.
Thank you.
Okay, the next and the last question will be from Dr. Pasica.
Wow, how did I get the last question? Hard to believe. Nicely presented, and obviously something near and dear to my heart.
Yes,
Did you just call me ma'am?
Sorry.
Okay. No, I know that's endearing in the southern
I'm sorry.
part of this country. Okay.
I apologize.
All right, no, okay, I'm going to take that as a compliment, and we're just going to go into 2 questions for you. I didn't see anything about medications, and we know that antidepressants can affect our executive function, so were all these people off their medications? And also, did you look at their vitamin D levels? There's recent reports showing that executive function is impaired in vitamin D deficient patients. But thank you very much, sir.
Thank you, for the Thank you. Yeah, for the neuropsychiatric medications, we actually did account for that in the manuscript. Unfortunately, with the presentation time limit, I didn't have enough time to get that in there, but we did account for that. We went through and anything that we defined what neuropsychiatric meds were, and then we excluded patients that were on those medications. We did not, though, look at the vitamin D levels, and I think that's actually a really good point and something that we'll include in our future studies. Yep. Thank you.
Thank you.
Thank you.
Our next presentation is Do Men Improve Their Bone Mineral Density 1 year after parathyroidectomy for primary hyperparathyroidism, results of a prospective study, presented by Dr. Frey on behalf of his co-authors Guillaume Warny, Gérard Bigot-Corbel, Bac-Dohu, Gaillard, Carew, Berrier, and Blanchard.
So thank you very much. Dear moderator, dear colleagues, I firstly want to thank the organizers for giving me the opportunity to present our work regarding the impact of parathyroidectomy for primary hyperparathyroidism on bone mineral density in men. My name is Samuel Frey. I am a resident in endocrine surgery in Nantes, France, and we have nothing to disclose. So, as an introduction, we of course know that bones are among the class C target organs of primary HPT, which decreases the bone mineral density, the BMD to make it shorter, while increasing the risk of fractures. That is why the last international guidelines recommend parathyroidectomy to be performed in asymptomatic patients with bone impact, including osteoporosis and asymptomatic vertebral fractures. That because there are strong evidences that parathyroidectomy actually improved the BMD. However, these recommendations are based on studies that included either a very large majority of women or only women, and they are applied without sex differentiation. But actually, the true impact of parathyroidectomy on BMD in men remains poorly studied and controversial. There is this first retrospective study, including 24 male patients who suggested that the BMD could improve after surgery at the lumbar spine, the femoral neck, and the total hip. In another study that has been discussed a few years ago in a previous AAES meeting, the majority of these men are expected to have at least a moderate improvement, while another retrospective study, but with a longer follow-up, suggested that this improvement could be moderate. So the aim of the present study was to evaluate the BMD and the bone remodeling biomarkers changes in a prospective cohort of men 1 year after parathyroidectomy. For that, we launched a prospective cohort in the Hospital of Nantes called the co-HPT cohort, in which every consecutive patients consulting for sporadic primary HPT since 2016 were included. The vast majority of them underwent parathyroidectomy and then were followed 1, 3, and 5 years thereafter to study many outcomes associated with parathyroidectomy and including, in our case today, the BMD. For the present study, male patients from the co-HPT cohort who were operated between 2016 and 2022 and also with available pre- and post-operative BMD measurement by DXA at the lumbar spine and the femoral neck were included, and especially patients with a follow-up shorter than 12 months were not included in this study. Our main outcome was the raw chain of BMD between baseline and 12 months after surgery at the lumbar spine, the femoral neck, the total hip, and the distal radius. And our secondary outcomes were the proportion of patients who had a significant BMD change, which was set at 0.03 grams per centimeter square, and also the bone remodeling biomarker concentrations change. You can see here that from 351 patients who were operated in this prospective cohort, 45 males were finally included in this study. Half of them had osteopenia at baseline and 11% osteoporosis. You can see that, of course, surgery significantly improved the biological phosphocalcic parameters. So here, I show you the mean BMD change between baseline and 12 months after surgery for each bone site. And you can see that in these 45 males, parathyroidectomy was associated with a significant BMD improvement at the lumbar spine, the femoral neck, and the total hip. So next here, I show you on the left panel, for each bone site except for the forearm because of the amount of missing data, the repartition of patients according to their baseline calcemia who had a significant BMD gain above the red lines, loss below the red lines, and no significant changes at all. And on the right panel, these are the same results but differently presented with the number of patients. And you can see from these panels that a significant BMD gain was observed at the lumbar spine in 44% of our patients, 51% improved at the femoral neck, and 47% at the total hip. And if we also take into account the forearm, despite the missing data, 24% of patients improved at this site. A total of 76% of our patients had a significant BMD gain at least one bone site. But of course, we know that for each patient, there can be at the same time an improvement at one or more bone sites, which is displayed on this graph, and also worsening at another site at the same time. So to try to take into account these simultaneous differential changes, we ranked our patients over a scale from less 3 to plus 3 by giving 1 point for each patient in case of significant BMD increase at one site and subtracting 1 point when a significant decrease occurs. So this is the repartition of our patients across this scale. And you can see from this graph that overall 64% of our patients had a global site BMD gain, including 9, so 20% with an improvement at 3 sites at the same time. While only 7 patients, 16%, had a global site BMD worsening, including none with worsening at 3 sites at the same time. And finally, I show you here the plasma concentrations of CTX, P1NP, and bone-specific alkaline phosphatases. And you can see that these concentrations significantly decreased after surgery. Of course, there are many limitations of this study, including the lack of unoperated patients taken as a control group, the monocentric design, the number of patients, the amount of missing data concerning the forearm, and also, of course, the fact that not all BMD measurements by the DXA were performed at the hospital of Nantes. So in total, in this study, in men, parathyroidectomy significantly improved the BMD at the lumbar spine, the femoral neck, and the total hip. 3 out of 4 men improved their BMD at least one site after surgery, while 64% had a global site improvement. And finally, as it has already been shown in women, the bone remodeling biomarkers were significantly decreased 1 year after surgery, suggesting decreased bone turnover. So these results actually support the current recommendations to operate on all patients with bone involvement regardless the sex. Sorry. Thank you very much for your attention.
Dr. Wilhelm?
Scott Wilhelm, Cleveland. Very nice presentation. I have 2 questions for you. Number one, most of the men that I see who have bone loss, the majority tends to be in the distal third of the radius. So I haven't seen as many men with, where you're showing 3-site loss. So do you have any information in terms of how long their disease process happened before you got to see them? And my second question is, did you guys correct or look for any testosterone levels in these men, especially in men with 3-site bone loss? Did you have any testosterone information if they had low T leading to bone mineral deficiency baseline?
So thank you very much for your question. To answer your first question, no, we don't have the duration. We don't have any idea of the total duration of the primary HPT process. However, in our cohort, we know that address to surgery was approximately 2 months, and it was homogeneous between our patients. I'm sorry, but I didn't understand your second question.
Men who have low testosterone levels oftentimes will also have bone mineral deficiencies. I was curious if you had any blood testing or information on testosterone levels in your patient population.
So your question is, does the BMD change depends on the baseline biological characteristics of our patients? That's your question?
Question's testosterone. Did you measure any testosterone?
Testosterone.
Eric Mirallier from Nantes. There's no evaluation of testosterone level in our population.
Low testosterone?
No, we didn't evaluate.
Thank you.
Back left.
Yeah, Sam Zuber, Endocrine North Shore fellow, no disclosures. When you were looking at the bone densities, did you also happen to look at the T-scores? And were there any changes, any patients going from like osteopenia up to like normal?
I'm sorry. Yes, we try to find many predictive factors of BMD improvement after surgery, including, of course, osteopenia. We used a linear regression model, but no, we did not find any significant association between baseline osteopenia nor osteoporosis with postoperative BMD improvement.
Right.
But that's a very good question. Thank you very much.
Thank you.
Peter.
Peter Mazzalia, Brown University. So did you have a chance to look at the PTH levels? Is there any correlation? Did you look at that between the baseline PTH and whether or not these patients improved subsequently? And my second question is, was there any difference between patients who had single adenomas and multi-gland hyperplasia in terms of their improvement?
Thank you very much for these questions. We also looked at the relation between baseline PTH and postoperative BMD improvement, and no, we didn't find any significant associations. And it was also the case concerning the histopathological results. But this could be the result of a low power of our study. Of course, we have only 45 patients. So this must be taken with what it is. So. But thank you for your question.
Thank you.
Thank you.
All right, our next presentation is Prevalence and Risk Factors for Dysphagia in Older Adults Following Thyroid and Parathyroid Surgery, presented by Dr. Crapeau, Sutton, Sally, Fedorova, Russell, Zeiger, Bandine Roche, Walston, Morris-Wiseman, and Mather.
Good morning, everyone. Thank you for the privilege of presenting our work here with you today. We have no disclosures to report, and sources of funding are below. Among the general population, the prevalence of dysphagia gradually increases with age due to atrophy of the cartilaginous and muscular support structures required for swallowing. Dysphagia among older adults in particular may lead to a lack of medication compliance, malnutrition, dehydration, and aspiration. Dysphagia has also been reported in up to 60% of younger adults following uncomplicated thyroid and parathyroid surgery, and typically resolves within 2 to 3 months. Because of the physiologic changes that occur with aging, older adults may be at greater risk of developing dysphagia following thyroid and parathyroid surgery. However, the incidence of postoperative dysphagia among older adults is unknown. Therefore, the purpose of this study was to first determine the prevalence of dysphagia among older adults before and after thyroidectomy and parathyroidectomy, and second, evaluate risk factors for its development. We leverage an ongoing longitudinal prospective cohort study of older adults aged 65 and older who underwent initial thyroid or parathyroid surgery at a single institution. Patients were excluded if they had prior neck or vocal cord surgery, if they had a loss of intraoperative nerve monitor signal, or if they experienced an intraoperative recurrent laryngeal nerve injury. We utilized the reliable and validated Dysphagia Handicap Index, or DHI. This was administered to each patient prior to surgery, and again at 1, 3, and 6 months postoperatively. The DHI is a survey composed of 25 statements evaluating swallowing function. These statements cover 3 domains of dysphagia: physical discomfort caused by dysphagia, the functional impact of dysphagia on activities of daily living, and the emotional reaction to dysphagia. Participants were asked to state how frequently each statement applied to them by responding with one of 3 answer choices: never, sometimes, or always. Points were assigned to each response for a total score of 100, with a higher score indicating a greater degree of dysphagia. Patients were considered to have dysphagia if they had a positive response to any of the questions on the DHI. At the end of the DHI, patients were also asked to self-report the severity of their dysphagia on a scale of 1 to 7, with 1 representing no dysphagia and 7 representing severe dysphagia. At the time of enrollment, we also determined each patient's freed frailty phenotype, which is a condition characterized by increased vulnerability to adverse health outcomes and is a predictor of surgical complications. This may predict a subset of patients at risk for postoperative dysphagia. Freed frailty is measured according to 5 criteria, which include unintentional weight loss, exhaustion, decreased physical activity, low grip strength, and slow walking speed. Patients were given 1 point for each criteria that was met. Those with 0 points were considered robust, those with 1 to 2 points were considered pre-frail, and those with 3 or more points were considered frail. For analytical purposes, pre-frail and frail patients were combined into one group. Changes in mean DHI scores at each time point following surgery were calculated using paired t-tests. Adjusted multivariable logistic regression was then used to determine risk factors for developing worse DHI scores following surgery. Regression models were adjusted for age, sex, race, preoperative dysphagia, frailty phenotype, BMI, smoking status, GERD, Charlson Comorbidity Index, malignant pathology, type of surgery, which included thyroidectomy or parathyroidectomy, and extent of surgery, which included unilateral or bilateral. Of the 175 patients included in the study, the mean age was 71.7 years, roughly 75% were female, and a majority of patients were white. 40.6% were pre-frail, and 7.4% were frail. The two most common diagnoses were primary hyperparathyroidism and multinodular goiter. 41% of patients underwent thyroidectomy, and 49% underwent parathyroidectomy, with the remaining 10% undergoing a combination of the two procedures. Additionally, 5% had a central neck dissection. 57% underwent a bilateral procedure, and 21% had a malignancy on final pathology. Of these patients, papillary thyroid cancer was the most common finding. Overall, we found that 77.7% of all patients had dysphagia prior to surgery. The mean preoperative DHI score among all patients was 6.48. In addition, the prevalence of preoperative dysphagia was 22.4% greater among pre-frail and frail patients when compared to those who were robust. When compared to preoperative DHI scores, 46.9% had worse scores at 1 month, 43.4% had worse scores at 3 months, and 49.1% had worse scores at 6 months. Compared to preoperative scores, the mean total DHI score increased by 40.7% at 1 month and then returned to preoperative levels by 3 months following surgery. The mean functional DHI score, which measures the impact of dysphagia on activities of daily living and is indicated by the green bars, increased by 105% at 1 month and by 51.7% at 3 months, returning to preoperative levels by 6 months. This indicated that ADLs were negatively impacted up to 3 months following surgery. The mean physical DHI score, indicated by the yellow bars, increased by 20.9% at 1 month and then returned to preoperative levels at 3 months following surgery. Patients were not emotionally affected by their dysphagia, as indicated by the orange bars. On the self-reported dysphagia scale, the proportion of patients who reported mild dysphagia increased at 1 month and remained persistently elevated throughout the study period. The proportion of those who reported moderate or severe dysphagia increased at 1 month, but subsequently returned to preoperative levels by 3 months. Because functional domain scores were most affected, several statements from the DHI questionnaire specifically relating to ADLs were further investigated. The proportion of patients who responded positively to the statements, "I cough when I eat solid food," and "I choke when I take my medication," were significantly increased at both 3 and 6 months postoperatively compared to preoperative levels. Additionally, compared to preoperative levels, more patients across the study period responded positively to the statements, "I have to swallow again before food will go down," "I changed the way I swallow to make it easier to eat," and "I eat smaller meals more often due to my swallowing problem." We then examined risk factors for dysphagia. After adjusting for covariates, the risk of developing worse functional dysphagia at 3 months was 3 times greater among those with preoperative swallowing dysfunction. None of the other covariates, including frailty phenotype, were associated with worse functional dysphagia, and we did not identify risk factors for having worse dysphagia at 6 months postoperatively. In conclusion, among older adults aged 65 and older, 78% had dysphagia prior to thyroid and parathyroid surgery. Those with dysphagia were significantly more likely to be pre-frail or frail. Additionally, compared to preoperative swallowing function, 50% had worse dysphagia at 6 months postoperatively, specifically impacting activities of daily living such as eating, drinking, and taking medications. Finally, having preoperative dysphagia was associated with a 3-fold greater risk of developing worse postoperative dysphagia. Older adults should be counseled about these risks prior to surgery. I want to thank my PI and my mentor, Dr. Arthi Mathur, along with all of the other amazing individuals who contributed to this project, and I'm happy to take any questions.
Yeah, I think in the back right. I'm sorry, I can't quite.
Shaha, New York.
Well,
Excellent study, wonderful. We have been observing these symptoms for a long time, but you have put it in right perspective with good analysis, so congratulations. This has been very well described both in Argentina and in Rome by Rocco Bellantone and his group. There are a variety of symptoms patients get after total thyroidectomy, and you have described them very well with the description of many patients. There is one other symptom they will tell, and that is, "I feel somebody is trying to strangle my neck." And this is not only common in old patients, but we have seen it commonly in young people also. And the reason behind this, which we have not discussed, is mainly the scarring and fibrosis. Thyroid gland is a sizable organ. You're born with a beautiful anatomy, and that is totally distorted. There is some kind of parasympathetic dysfunction near the cricopharyngeal junction, which we dissect around the thyroid, and there is motility disturbance to the beginning of the cervical esophagus, which leads to all these symptoms. I think you may want to look into this, and your manuscript will become much stronger. Thank you.
And thank you for that comment. I appreciate it. To address your first comment or your first question regarding strangulation and the strangulating sensation, that was one of the questions or statements on the DHI questionnaire, the strangling sensation with drinking and the strangling sensation with swallowing. And we did see a significant proportion of patients, greater than 50%, report both of those sensations both before and after surgery. And then to your second point regarding scarring and fibrosis, that certainly is one of the mechanisms of dysphagia following surgery. We included patients who had intact recurrent laryngeal nerve function. These were uncomplicated surgeries. And so dysphagia following these surgeries certainly could be due to the postoperative scarring and fibrosis in the neck.
Back left.
Good morning, Jacob Moalen from Rochester, New York. Did you have any patients in your population for whom the indication for surgery was dysphagia? So I'm thinking about a patient with an intermediate-sized nodule, maybe 3 centimeters, biopsy benign a couple of times, but the patient complains of persistent difficulty swallowing. They've had a barium swallow, they've had a full workup for it, no other cause for the dysphagia is evaluated, and so you're left with either doing or not doing thyroidectomy. It's a pretty common presentation in my practice, and I'm curious about that specific population.
Yeah, that's a great question. We didn't specifically look at patients who were sort of borderline whether or not they were going to have surgery and were sort of pushed towards surgery based on whether or not they presented with preoperative dysphagia. So we didn't look at that group, and that certainly would be an interesting subgroup to look at. What we did find, though, with our subgroup is that we did have a significant proportion of patients who presented with dysphagia, over 77%. And we found that in each of these individuals, when compared to their preoperative DHI scores, their scores or their dysphagia got worse up to 6 months following surgery in up to 50% of these individuals, which suggests that patients who present with dysphagia prior to surgery, there are some patients who may have worse dysphagia, worse swallowing function after surgery.
Thank you.
Thank you.
And the last question due to time constraints will be Dr. McHenry.
Thank you. Chris McHenry from Cleveland, Ohio. I have no disclosures. Congratulations on a really nice presentation. My comment is that both preoperative and postoperative dysphagia etiologies are multifactorial. But your comments or this dysphagia, this same entity can be seen in young patients. And I was just curious why you chose to only look at this in individuals over the age of 65. I would think that we see this in younger patients too, and I think it would be nice to even compare, see what the outcomes are in younger patients, and even compare your younger patients to your older patient group. Again, nice presentation.
Thank you very much, and that's a great point, and your point is well taken. Certainly there is literature to describe dysphagia following surgery in a younger population. In fact, most of the literature focuses on younger adults. And we hypothesize that with aging, as patients become more frail and as they become more sarcopenic, the risk of dysphagia may be worse in older adults. And because of those reasons, we wanted to focus specifically on dysphagia in this population.
Thank you so much, and also happy birthday.
Thank you.
Our next presentation is the impact of hormonal secretion on survival in adrenocortical carcinoma, presented by Dr. Sada on behalf of her co-authors Foster, Alward, Sawani, Shashar, Pishad, Ben Shiomo, Dai, Leiden, Bergsland, Jassim, Raj, Oksana, Hamidi, Hamrahian, Shambo, Sugi, apologize, Forgoso, Graham, Habra, and Bancos, and Mackenzie.
I want to thank the Aaes for giving me the opportunity to present, and I want to also thank all the listed authors who contributed to this multi-institutional study. Do I control it from here? Oh, perfect. Two of our authors have the listed disclosures which are not related to this work. Current evidence suggests that cortisol-secreting adrenocortical carcinoma, or ACC, has worse prognosis compared to non-secretory tumors. However, the impact of other secretory subtypes on survival is largely unknown, specifically the impact of androgen-only secreting tumors and also mixed cortisol androgen secreting tumors. Therefore, we aim to evaluate the clinical behavior of different secretory subtypes of ACC. We conducted a retrospective multi-center international study using the A5, the American Australian Asian Adrenal Alliance. And we included adults diagnosed with ACC between 1997 and 2020 from 10 academic tertiary centers. Secretory subtypes were defined as categorical variables, and all patients in our cohort were tested for at least hypercortisolism. Hypercortisolism was defined based on an elevated cortisol, either with a late salivary night cortisol test or 24 hours urinary test, or based on 1 milligram dexamethasone suppression test. Overt hypercortisolism was defined if the patient has obvious Cushing syndrome, while mild hypercortisolism was defined by the presence of biochemical hypercortisolism without Cushing syndrome. Hyperandrogenism was defined by an elevation in DHEAS, testosterone, or androstenedione, while mineralocorticoid excess was defined by an elevation in aldosterone or 11-deoxycorticosterone with the suppressed plasma renin activity. And we compared overall survival and disease-free survival between the different secretory subtypes, which included cortisol-only secreting tumors, mixed cortisol androgen secreting tumors, and androgen-only secreting tumors, in addition to non-secretory ACC. We excluded the mineralocorticoid secreting tumors from the survival analysis, giving the extremely low number of patients. We had a total of 807 patients. 91% were evaluated for hypercortisolism at the time of initial diagnosis, and 76% were evaluated for hyperandrogenism. And after excluding those who were not tested for cortisol and those with insufficient data, we had a total of 719 patients in our secretory subtypes. Of those, 24.5% had cortisol-only secreting ACC, 28% had mixed cortisol androgen secreting tumors, 13% had androgen-only secreting tumors, and 32.5% had non-secretory tumors. The mineralocorticoid-only secreting ACC represented only 2% of our entire cohort. In this graph, we looked at the TNM stage breakdown by the secretory subtypes. And overall, we found that ACC tend to present with advanced stages, specifically the highest rate with the stage 4. And that was the case when we looked at cortisol-only, androgen-only, and mixed cortisol androgen secreting tumors. However, we found that non-secretory tumors and also mineralocorticoid secreting tumors tend to present at earlier stages. Specifically, they were more likely to present with stage 2. Ki-67 was reported for about 2/3 of our entire cohort, and we did not find a significant difference in the median Ki-67 among the different secretory subtypes. When we looked at the rate of surgery versus no surgical treatment, we didn't find a difference in the secretory subtypes. And overall, about 90% of our entire cohort underwent surgery. Now, when we looked at the type of surgical resection, whether it was complete R0 versus R1 or R2, we found a significant difference between the secretory subtypes, but overall, about 60% of the entire cohort underwent complete R0 resection. When we looked at the rate of receiving adjuvant treatment after surgery, we did not find a difference in the different secretory groups, and overall, about 60% of our entire cohort received adjuvant treatment. Now we are going to talk about overall survival. When we looked at overall survival, we found that the worst overall survival was for the mixed cortisol and androgen secreting tumors, and that's followed by cortisol-only secreting tumors, and then androgen-only secreting tumors, while overall survival was the longest for non-secretory ACC. Now, when we looked at overall survival by the degree of hypercortisolism, as expected, worst overall survival was for the overt hypercortisolism compared to patients who had mild or no hypercortisolism. Now, on multivariable analysis, including all comers, and we were evaluating the overall survival after adjusting for the clinically relevant factors, which are age, sex, secretory subtypes, Ki-67, TNM stage, resection status, and adjuvant treatment. We found that mixed cortisol androgen secreting ACC were associated with worse survival compared to non-secretory tumors. However, cortisol only or androgen only were not. We found that higher Ki-67 was strongly associated with worse survival, in addition to advanced stage, incomplete resection, and also no treatment with adjuvant therapy. Now, on multivariable analysis, including patients with non-metastatic disease, which are like TNM stages 1 to 3, who underwent complete R0 resection, and after adjusting for the same clinically relevant factor that I mentioned before, we found that secretory subtypes did not impact their overall survival. Again, higher Ki-67 was associated with worse survival. Now, when we looked at disease-free survival, we did not find a significant difference in the recurrence rate between the different secretory subtypes. The non-secretory graph was a little bit separated, but again, this difference was not statistically significant. When we looked at disease-free survival by the degree of hypercortisolism, we found that similar to overall survival, overt hypercortisolism tend to have worse disease-free survival compared to patients who have mild or no hypercortisolism. Now, on multivariable analysis of the disease-free survival, including TNM stages 1 to 3 who underwent R0 resection, and after adjusting for the same clinically relevant factors that I mentioned before, we found that cortisol-only secreting ACC was associated with worse survival compared to non-secretory subtypes. Higher Ki-67, specifically above 40, was associated with worse disease-free survival, in addition to stage 3. So in conclusion, we found that mixed cortisol androgen secreting ACC was associated with worse overall survival, while cortisol or androgen only secreting tumors were not. And notably, among patients who underwent complete R0 resection, secretory subtypes did not impact their overall survival. And it's important to note that we don't need to overlook the cortisol-only secreting ACC impact on outcomes, as these patients tend to have worse disease-free survival. And the most important message is Ki-67 is a really strong predictor of worst outcomes, independent of stage and independent of other clinically relevant factors. And again, I want to thank the A5 and all the contributing centers, and I'm happy to answer your questions.
Okay, this paper is open for discussion. Is there someone in the back?
Yeah, hi, Matt Aaes, Boston, no disclosures. This is a tremendous amalgamation of patients. It's 800 patients. Congratulations on this great study. These tumors are highly glycolytic, and they use glucose as an input. And I think that the state of hypercortisolism may be a teleologic end for the tumors. In other words, I think that they know what they're doing. The most aggressive tumors may therefore be making cortisol in order to augment their growth. So my question here is, did you look at glucose levels? Did you look at hemoglobin A1C or the presence of diabetes among these different hormonally secreting subtypes to know if there was a difference between those two groups?
Unfortunately, we did not look, but I agree with you, that's an interesting point. But we did not collect data about hemoglobin A1C or the hyperglucose levels.
Thanks.
Dr. Wachtel?
Heather Wachtel, University of Penn. I have no disclosures. Really beautifully presented, and I think this study actually attests to the power of a collaborative multi-institutional study because you're able to get a lot of granular data that you wouldn't able to retrieve from a national registry. You know, these findings are consistent with what has been previously shown, and it really begs the hypothesis, which I think is what Dr. Aaes was getting to. Are these tumors actually creating a cortisol-rich microenvironment that's immunosuppressive and leading to allowing the tumors to escape the body's immune response? My question for you was really whether you were able to look at therapies that were specifically targeted to the cortisol excess, and if that impacted any of your findings, either with disease-free or overall survival.
We did not, thank you for your comment. We did not look specifically at targeted, like therapy. What we did is when we looked at the adjuvant regimen, we categorized them in mitoten only versus mitoten and chemotherapy, plus or mitoten versus chemotherapy plus radiation to the, local adrenal field. In terms of the, based on this, broad categories, we did not find a difference in the groups in terms of the rate of treatment, but we didn't go into details about the agent that they were used, like in chemotherapy, what else was utilized. Just because, it's on a to categorize them into multiple variable, if we keep going into subcategories, it's gonna be hard to, reach the numbers, even though it's a large cohort.
Thank you.
Thanks.
Thank you. So that concludes the session. We're going to move straight into the health equity session.